on our health system and the well-being of all Australians. But for many reasons, the broader health sector has been slow to seize the opportunities. We know the potential benefits are there, but have yet to be fully realised. One part of that digital health system is the exchange of valid information for diagnosis, treatment and prevention of disease and injuries, research and evaluation. E-health. A fully functioning national e-health exchange could save taxpayers $2.5 billion a year within a decade. Savings that would come partly from more efficient operations, but also with better informed treatment decisions, fewer adverse events, less avoidable hospital admissions, and the reduced duplications of medical tests. We would have savings through better health outcomes for patients. And surely this is the best win-win situation, better health outcomes in a more cost-effective way. It is estimated that there would be an additional $1.6 billion a year in savings for the state and territory governments for the same reasons. A properly functioning e-health record will help patients avoid unnecessary adverse medications reactions, allergic reactions and other illness. And just as importantly from the health consumer's perspective, they will reduce the effort and time spent providing repeated medical histories at every contact with the health system. Now is the time to make a determined and collective effort to make the digital world an accepted and widely used part of our health environment. Since becoming Health Minister, I have endeavoured to speak with as many people from as many different areas of the health portfolio as possible. I've taken the points of view I've heard on board on this and other issues. We've provided $485 million to redevelop the e-health system and push it up to the threshold where it will be used and relied upon to deliver the benefits to patients, clinicians and governments. What I will be focused on throughout is what it means and what it delivers for consumers. Digital technology and digital usage by consumers changes by the year. What we thought 5 years ago may be the future is constantly superseded by innovative technology and by what the consumer actually wants, not just what we think they want. The consumer will drive this change in the healthcare environment. It's important as providers, developers and governments that we recognise this. What government can do is empower and facilitate consumer-led change. This needs to be seen as a consumer health system and not just an IT system. So first and foremost, the PCEHR will be renamed My Health Record, a simpler and clearer message to consumers about what this actually is for them. We also need to increase the number of patients who have electronic health records. There's been a poor uptake of the previous PCEHR, a combination of complexity, poor communication, and not implementing what will drive that uptake. Hence, we will be moving soon to an opt-out model. Patients will still have the option to control who can add to their record and who can use it. Trials of these opt-out arrangements will be conducted next year, probably starting in April. The people in the trials will then be given 2 months to opt out, if that's what they choose to do. If they choose not to opt out, they will be registered in the My Health Record system and have several weeks to access their record and apply access controls before their My Health Record is accessible to their healthcare providers in mid-2016. This is the opposite of the current situation where people need to actively register in order to reap the potential benefits. I expect there will be up to 4 opt-out trial sites. I'm talking to the states and territories now about possible sites and I expect to finalise those shortly. As with the introduction of any large-scale change involving systems, the success of My Health Record will rely on people finding it easy and worthwhile to use, and patients and clinicians seeing the potential benefits. The government will take steps to raise awareness and provide access to education and training materials for doctors and other healthcare providers, so that they are able to reach a level where they can confidently use the system for their patients. We will also give them a bit of encouragement. The eligibility requirements for the Practice Incentives program for GPs are being reviewed, and the changes will require doctors to actually use the system to continue receiving the incentives, not just have access to it. They may, for example, be required to upload shared health summaries for a proportion of their patients, and we will be consulting with peak bodies on these changes. From a governance perspective, there will be one entity overseeing all national e-health systems, the soon-to-be-created Australian Commission for E-Health. This is well underway. The implementation task force that will design and establish the Commission is expected to start operations very shortly. This task force will put plans in place for the transition of functions and people to the Commission from the National E-Health Transition Authority, NETA, and the Department of Health. This is expected to be fully operational by July 2016. We need to be honest about the path ahead. My Health Record won't deliver its full benefits for some years. It will take time, even with a better take-up rate by patients and clinicians, to build up the clinical data held in each person's record. We need to acknowledge that the benefits will flow sometime after we have broad use by patients and providers. But it's possible for individuals to get a benefit from My Health Record almost immediately. For instance, anyone who has an allergy to penicillin or another condition knows how vital it is that they be correctly diagnosed in an emergency. The My Health Record can provide access to this information, but only if the patient has one. Without My Health Record, it's up to the patient to tell the doctor. That brings the questions up of what if they can't communicate this? How can the right decision be made quickly if medication is required? More than 380 hospitals and around 5,200 GP practices across Australia are registered to use the My Health Record system to access patient records and to post-discharge summaries, shared health summaries, and various other clinical documents. If crucial information is on the record and available to that hospital or doctor, it could save your life tomorrow, or your parent's life, or your child's life. It makes so much sense to have a single record literally at your fingertips for both you as the patient and for those of you who are also doctors and healthcare providers to better treat your patients. I'm determined to get this improved system up and running, not stuck at the starting post again. We don't need it to be perfect right now. In fact, innovation and consumer choice will ensure that what we think consumers want now will be superseded very quickly. Not to mention changes that will occur in clinical practice and service delivery over the next decade. What we need is for My Health Record to be functional, practical and beneficial right now. Let's get some experience before we build longer-term plans. Our experience from using this system will give us more practical insights about how this should evolve, rather than enhancing a conceptual but unused model. I hope that in the years to come, My Health Record will be well accepted by both providers and consumers, and will become commonplace in the same way that Facebook and streaming music from an app have become. My Health Record has the potential to help you as informaticians and us as parents and our children to better understand our health and to self-manage our wellness and our conditions. So like you, I believe in an Australian digital health system, both as the Minister for Health and as a health consumer. Our focus now is to take My Health Record and turn it into something that delivers tangible and real benefits for the patient. Thank you. And now I understand I'm taking questions, so I'll hear them but I won't see them. Yes? Who has the first question?
Microphone or?
Yes, I can.
It's George Margellis from Intel.
That's better, the light speaks in a tiny bit dimmer, I think.
Thank you, Minister, for your presentation, and thanks for the support for the industry. Collaboration with the rest of the industry. Is there a program around working collaboratively with IT vendors, software vendors, healthcare providers to make a more collaborative model going forward?
Yes, there will be, in short, and government will support those collaborations. But I really do want to say that government shouldn't be orchestrating them, and providers and people interested in this space should step forward and do what organically, the IT marketplace has always been so good at doing. And I think that's one of the failures. I mean, we've learned from the previous system, and I'm not here just to be critical of it because it was the previous government. I mean, obviously, I think they've got the opt-in, opt-out round the wrong way. But I hope that the investment that we're making, the $485 million over 4 years, will give the sector the confidence to say, I know what would work. Talk to the, the Commission once it's established soon. Liaise with other software providers, but most importantly, talk to doctors and patients. So doctors say to me, I don't like that the usability is poor, it's too hard to move between screens. And that is said to me all the time, it's too hard to move between screens. So you don't need the government to tell you how to do that, you need the sector to step up and say, let's make this good, let's make it useful.
And also with the new Digital Transformation Office, there'll be part of integration so that it's part of a national solution, not just in health, but making the whole country more digital.
That's a very good point.
Thank you.
Microphone from nowhere. Thank you, Minister. Yes, that's I support and applaud your idea that actually it's us who should be driving this now, which I think was the original idea in the conception of the personal health record. Now, my question is, later on this morning there's going to be a presentation on what the City of Logan is doing, led by the RDA, in mustering up all of the resources in the City of Logan that can underpin wellness and health and people managing their own chronic disease or others. Part of that will be building an app environment. So, for example, the first one will be for palliative care to support the family members who are supporting someone either at home or in the hospital. That will be all the information that we can muster together to support that person. Ideally, we'd love to be able to create a connection from that secure system, which will be hosted in the Secure Government Centre in New South Wales, probably, and the My Record. Now, originally there was a back end, there was a way in which other apps could talk to the system as well as the current front end. That was the original thinking. So what we're looking to do is, if it's possible, to be able to support those endeavours. This is what we're going to be doing in any case. But if we can have access through that business-to-business link, we can get the adoption of many people in the Logan area. So, for example, with palliative care, to have that information where they might be going in and out of the hospital. We know that the state government is committed to pushing out all the information of hospital discharges into that record, and it would be so useful for the pet, usually it's the daughter who's looking after the palliative care, that they can have access to that information within that app as well, so they can coordinate everything. If that's possible, how would you best suggest that this project move forward to collaborate with your initiative?
Well, thank you. And I have heard of the project in Logan. I was there with my colleague Bert Van Manen not that long ago, talking to pharmacists actually, and it was mentioned to me by quite a few people. So it's interesting. I don't know the details of how we would need to make those linkages work, but I think ideally they should. Clearly there are protocols within the existing system, and your talk of palliative care certainly makes me think that the linkage with the state hospital system is vital, and the ability to share the information from within inside the health service is probably a reasonably, probably a bit of a barrier, but that project is a good example of how we can overcome some of these challenges and see how it happens. So I'd love to take the conversation offline and work out what we can do to help.
Thank you.
Simon James here from Pulse IT magazine. Just as a question about the PHNs, I understand that one of the planks of the new network is e-health, and I'm just curious if you could shed some light on what roles you see PHNs having with regard to e-health broadly.
Well, as you all know, the PHNs are superseding Medicare locals, and their framework of operations broadly is that they will need to report to government, report to me, about how in their various areas of health operation they are improving health outcomes. So we've given them key targets, and we've certainly mentioned e-health as a key area in which they should operate. Ultimately though, what they will be doing is saying health has improved in our population in this way by this much. And what government should be saying to them is not micromanaging a contract, easy though that is for departments to do, but giving them the resources and the ability to get on with it. And ultimately, I would like to see being paid on that outcome, because too often these initiatives get bogged down in an array of administrative and all sorts of activity that sound like health, but if you're a patient in that particular area, do you get any benefit? Not always. So yes, we've said please use e-health. Every area will be different because every hospital service is different, every state government takes a different approach, and the linkages are or aren't there to a certain degree. So again, as I said in my remarks, it won't be perfect to begin with, but use what's there, and where you can allocate resources, I'll be very happy for the PHNs to do exactly that. Remember, they're very well resourced. There's about $900 million over 3 years for the networks across Australia. So we look forward to some good ideas from them. There's a lady here. I'm just pointing at her.
Thank you. Are you aware that we don't have the capacity in the workforce to really be optimising the use of the technologies that we currently have? Do you have any plans for any sort of funding initiatives to assist not only preparing the existing workforce to do things better, but also the future workforce? We're having a major difficulty in integrating health informatics into any of the health professional programs that are currently being delivered by the universities, because most of the educators know very little about health informatics as a discipline. And we really desperately need to improve the situation so that the workforce is better prepared to optimise the use of available technologies.
Well, you've raised a series of challenges which I take very seriously. Is there government funding? No, there's not. Before this role, I used to be the Assistant Minister for Vocational Education and Training, and I spent a lot of time discussing not exactly health informatics, but this type of problem or challenge. In other words, how does a rapidly moving environment get properly reflected by educators who produce the graduates? And I've been discouraged and encouraged at the same time, so sometimes I'm discouraged when I hear stories about how a particular course just hasn't caught up, but then I hear of something that's happening that's absolutely stepped up to meet the skills. We do have, of course, an ability through our visa system to bring people in who are on occupations in demand. I'm not sure that these would be reflected here. In fact, I'm quite sure they're not. But it's perhaps we can talk about how we can get some networks which include the educators, the training colleges, the universities to, if you like, be aware of what's happening in this field when, if their individual educators are not, the gap that you spoke of gets wider. I know that the New South Wales TAFE system says to everyone who is training in a particular field, they must link continually with the developments in that field. I don't think every system does that, and I'm sure every TAFE, and I use that term generically, doesn't do it as successfully as it might. But in fact, that is a measure that says, okay, if you're teaching this, you need to get out there and understand what's happening in the real world and equip yourself accordingly.
One more question? Yes, you can take one more question.
Yeah. Thank you, Minister, for what you said. Part of what you were saying also was that over time, things might get superseded even in what we're currently doing. As a health consumer, I have a computer in my hand, it's my mobile phone. Not only do I have applications, but I also now have a platform where I'm integrating all my own personal data. personal encrypted cloud, and I'm the point of integration for all the services, as opposed to my health record essentially being a centralised silo. So as going forward, just like in energy, you had the decentralisation with rooftop solar. So as you're building out your My Health Record in a big silo, I have all my own data, and what I'm really describing is just as you're doing what you're saying you're going to be doing, the metaphor of the energy sector where the central generation and then distribution, health consumers are going to be having their own rooftop solar. And I wonder to what degree the government will play whack-a-mole with that, like to some degree seeing rooftop solar as an enemy to that kind of central system, and whether we could have a dialogue about what capability is already in the hands of consumers that potentially might even supersede some of what My Health might do.
Well, I'd be delighted if it did. I don't mind your analogy, but it's probably not much of an analogy given that your perspective on rooftop solar is that it's not allowed to grow because of government controls in the energy sector and doing it all from above. I think it's fantastic if the initiatives that might come from app-based, tablet-based backing happen almost in spite of what we're doing, because then we will know that we will have exactly what the consumer wants, and at the appropriate point in time, yes, government would be there to support, and obviously the architecture of the e-health system is built and it remains there for those further developments. I'm sure that if this doesn't happen, then someone else will do it. Google will do it, Apple will do it. They're already doing applications that revolve around an individual's health, and I think it's perfect because the modern younger generation, I say, and having 3 children in their 20s, are absolutely fascinated with themselves. And if you do something that links to their health in a way that excites them, then it won't be a desktop computer in the doctor's surgery that they really have no interest in how that relates to them. And of course, the key thing that you've really picked up on is that this then becomes about preventing you getting sick in the first place and your wellness, which is, after all, our #1 goal. So thank you.